continuing with our program, we're really privileged to have Dr. Larry Sharp here today. Dr. Sharp, welcome.
Thank you.
Is it okay if I call you Larry?
Yes, that's fine.
Okay. Larry, you are a medical doctor.
Yes, I am.
Tell the viewer a little bit about your background.
I received my Bachelor's of Arts from Rice University in Houston, Texas.
Tough school.
A little tough, yeah.
Yeah.
And my medical degree from the University of Texas Health Science Center in Houston.
I see. And where do you practice medicine?
I practice here in Wichita Falls, Texas.
You've been a doctor for how many years?
Since 1983.
Larry, what would you say the percentage of your practice, your medical practice, would be devoted to folks, say, over the age of 60?
I would say easily, at least the patients I see in the office every day, half of them are over the age of 60.
And in your practice, do you deal with folks who are exhibiting symptoms of Alzheimer's and Parkinson's?
Yes, yes I do.
Larry, I would like for you to be able to give the viewer sort of a bird's eye view of these two diseases. Would it be better to take them one at a time?
Probably.
Okay, let's start with Alzheimer's.
Okay.
Larry, can you tell us some of the benchmarks that you look at in making a diagnosis of Alzheimer's disease?
The first thing that usually happens with Alzheimer's disease is recent memory loss. The family brings the patient in because they can't remember recent things. Things that happened just within the last couple of days. They keep asking the same questions over and over again of the family member, or they forget where they were going, they forget what they were doing. They'll start a meal and leave the stove on, and something burns or something catches on fire even. So recent memory starts fading, and the family is concerned about that. That's usually the main complaint. Sometimes it's a behavioral problem right away. Sometimes they present looking depressed as a first symptom. But that's the benchmark symptom, is usually a recent memory loss problem.
Okay. But now, I've noticed as I get older, my memory seems to not be as good as it was. Is that something that people need to be immediately concerned about if we don't remember a name of someone that we know?
No, not really. What I've generally found is that someone who's aware that they're not remembering things and they're not afraid to admit that, then there's not a problem. Generally, Alzheimer's patients don't want to admit they have a problem. They're in denial, they start compensating for it, or they try and talk their way around it. I'll have patients who will come in, or their family brings them in, and they will readily admit that they do have a memory problem, that they're aware of it. And when the family member or the patient himself says, yes, I'm having problems with my memory, and they're easily admitting it, then they probably don't have an Alzheimer's dementia, because Alzheimer's patients tend to hide it. They tend to try and compensate for it and deny it.
Okay. Now, if you're trying to confirm Alzheimer's, is there any way to confirm it?
There's not a definite test for Alzheimer's. The only definite test is a brain biopsy. And if you do a brain biopsy, you're going to destroy brain tissue, so it's not a good test.
Okay.
It's a diagnosis of exclusion. There are other disease processes that can look like an Alzheimer's dementia or any other type of dementia. And what you have to do is exclude those other disease processes. And you do that through a series of blood tests, possibly with a CAT scan or an MRI of the brain, and a urine sample. And once you determine that the patient does not have any of these other disease processes, then by that process of elimination, you say it's Alzheimer's disease.
Now, you used a hyphen. You said Alzheimer's dementia. I heard you say that earlier. What's the difference between Alzheimer's and dementia?
Well, Alzheimer's is a type of dementia.
Okay.
Dementia is just a definition of a progressive neurologic illness where the patient gradually loses his cognitive function, his ability to reason. And it usually starts with memory loss, and then they gradually lose their ability to use their rational thinking behavior, their ability to add, subtract. logical reasoning, those functions just gradually deteriorate. And that's a dementia type picture. And it goes on and on to other bodily functions in the later stages. But there are multiple different types of dementia. Alzheimer's is the most common.
How do you stage Alzheimer's?
It's by the severity of the symptoms mostly. Early on, there's just a mild memory loss problem. The patients are generally pretty calm and don't exhibit a lot of behavioral disorders. Towards the middle of the disease process, you see the memory problem becoming more pronounced, and that's where you see a lot of the behavioral problems start.
Such as?
They can get violent. There's violent acting out, and it's particularly bad right around sundown. In fact, it's called sundowning. As the sun goes down and there's less light, something happens with less light stimulation, and they become more disoriented is what the theory is. And when they become more disoriented, then they become more afraid or more paranoid. And the paranoia leads to some violent behaviors, and they can hurt people. And that becomes a danger to family members, particularly if it's a male husband or father who has the dementia and becomes violent, and they are a lot stronger or larger than the female family members. You run the risk of injury to family members there.
What about firearms, knives? I mean, is that something that they need to think about?
Certainly, yeah, those sort of things need to be taken away and hidden and not made available. It would be a little unusual for that to happen, but it's certainly possible, and it needs to be taken away. Those probably would be something more apt to be misused earlier on, but they could happen at any time. Then as the disease progresses, the violent behaviors become less pronounced because the patient is less functional. And as he becomes less functional, he's just less active. He or she is less active and less apt to do those sorts of things just because they're more vegetative.
So in a typical, and I don't know if typical is the right word, but I'm going to use it anyway. In a typical Alzheimer's patient, from the time that you diagnose them as having exhibiting memory loss to their death, can you tell the viewer what your experience is with these type of patients?
You know, there's not a typical patient. That's the problem with Alzheimer's disease. Everyone is individual. The symptom progression usually, I guess an average is over like 10 years.
Really, that long?
It can, yeah. But that's not necessarily, you know, it can be shorter, it can be longer. A lot of times these patients have been living alone for a long time and exhibiting the symptoms, and no one knows it because they've been alone so much at the time. And so it may have been going on for 3 or 4 or 5 years before somebody picks up on it because they've been alone so much at the time. And then all of a sudden a family member comes in from out of town and the house is a shambles because they haven't been able to care for themselves. And they just haven't been able to do these sorts of things they could do before. So, you know, by the time they're diagnosed, they may be halfway through the disease process. So it just kind of depends on where you pick it up. But the process can last up to 10 years or longer. But by the same token, it can progress and take only 2 to 3 years, just depending on the severity of the illness.
Can Alzheimer's actually be the cause of death?
I have listed it as a cause of death before, yes, because it leads to gradual inability to function. And once you get to a point where you're not able to eat on your own and not maintain your own life sustenance, then yes, it could be a direct cause of death, because if you can't eat and can't maintain your own life, then that's what caused you to not be able to eat. That's what caused your death.
What is the age range that you typically see of Alzheimer's patients?
You know, it varies. It can start as early as 60. Generally, it's older than that. Generally, it's someone typically over 65. Most of the time, it's someone over the age of 70 that I see in my office.
Do you see a genetic predisposition to Alzheimer's? If my parents had it or my siblings had it, I may have it. Is there any connection there?
It does tend to run in families. Right.
If someone has been diagnosed with it, if you've diagnosed someone with Alzheimer's, what kind of medical treatment is available?
The only treatment available for it now is medication that slows the process down. There's no cure. Some people are working on things. Some people are working on a vaccine, I believe. But there's nothing to cure it. There's just medication that slows the process down.
What are some of these medications?
There's Namenda, Exelon, Aricept are all medications that are designed to help improve cognitive functioning and memory. But again, they don't cure it. They just slow the process down.
Do you see those working for every patient, or?
No, they don't work for every patient. One medicine may work in one patient and not in another. Certainly, not every patient's going to respond to each of the 3 medicines. You have to sometimes do a trial and see if one of the medications will work in them at all.
Okay. Larry, let's kind of change focus just a little bit from the medical aspects of it to the family that is caring for mom or dad or brother or sister who is showing Alzheimer's related problems. What kind of counsel as a medical doctor can you give to these folks?
You know, I think the family member has the hardest job in this sort of situation. You know, the patient certainly is the one doing the deteriorating, but to a certain extent, once they get to a certain point, they're not aware of it. You know, they're not aware that they've deteriorated this far, and they don't remember it. Their short-term memory is so bad that the things that they're going through and the things they may yell out about, they don't remember it an hour later, even. So I always encourage everyone to get involved in an Alzheimer's support group.
What kind of support groups are there for Alzheimer's?
There's specific Alzheimer's support groups called Alzheimer's support groups.
All right. Okay. Are there here some in Wichita County?
There are. Okay. And they can help quite a bit. There's certainly a website, I think, for Alzheimer's support group, and they can direct you to that sort of thing. There's a lot of material available for Alzheimer's family members. And they're going to need a lot of support and counseling because they're going to have some difficult decisions to make.
Such as?
Well, the first thing you need to do when someone has Alzheimer's disease is you need to make sure that durable power of attorney is in order. If the patient still has capacity to assign the durable power of attorney for medical care and other affairs, that needs to be done as soon as possible, so that there's no.
I wholeheartedly agree with you.
So there's no problem there. So there's no problem with medical decision making. So there's no problem with legal decision making.
Exactly.
All of that needs to be done as soon as possible.
Right.
And that will help smooth the way for a lot of the problems. And then the other decision making is going to be how are you going to care for mom or dad.
Do you see situations where you've got an elderly couple, let's say in their 70s, 80s, and dad is exhibiting Alzheimer's symptoms, and mom is still pretty spry and wants to care for dad until the end?
Sure.
Do you ever see any bad things happen as a result of that game plan?
They sure can. I alluded before, if dad gets violent in that situation, there can be injury to mother. The other thing that happens is just exhaustion, because it becomes, it's 24/7 at some point, and mom's going to need help with that situation.
Or else mom may get herself in a fix, huh?
Right. She'll start having physical problems. Now, interestingly, though, the majority of Alzheimer's patients are women.
Really?
Yes. It's a higher percentage of Alzheimer's patients are women rather than men. Now,
wonder what the ratio is. Any idea?
I don't know what the ratio is.
Okay.
Some of this may be related just to the fact that women have a longer lifespan than men do. So they live longer, they're more likely to become demented.
Right.
But there are more women than there are men who have Alzheimer's disease. So you're probably more likely to see the husband as the caregiver for the wife than you are the other way around. So it's not quite as bad in terms of the injury problems, but of course they do arise. But in either scenario, the husband's going to get exhausted too.
Yeah.
And so you've got to have some sort of support system available for the caregiver to get respite care, to get respite from the care that they're having to give.
How can they get that kind of care?
That's a difficult situation if there's not family members readily available in town. it's tough.
Ultimately, maybe the nursing home is the only
That
solution.
may be, yeah. An assisted living center or nursing homes may be the only way there is. There are a couple of assisted living centers who do have Alzheimer's units in town. There's a nursing home with a specific Alzheimer's unit in town.
Have you had an opportunity to actually see those facilities?
I have seen the nursing home Alzheimer's unit. I've been to the assisted living center that has an Alzheimer's unit, but I've not been in their Alzheimer's unit.
How do they distinguish their Alzheimer's unit from their non-Alzheimer's unit? I mean, what are the distinguishing characteristics of that?
Well, it's a locked up area compared to the other units, and they have, I think the staff ratio is a little higher. Staff to patient ratio, I believe, is a little higher. And the nurses and the aide staff, I believe, is trained a little more specifically with Alzheimer's disease, and so they know a little bit more how to deal with those sorts of disease processes.
Well, Larry, I think we pretty well have the Alzheimer's disease covered. Is there anything else that you can tell the viewer that comes to your mind about this disease? Anything else on your mind?
Right. No, you just need to, once a diagnosis of Alzheimer's dementia is made, the family needs to get together and meet and really talk long and hard and make difficult decisions early on and stick to them. Specific decisions about artificial life support. That's the problem I see with patients that I deal with, is family members don't talk early on about artificial life support. And I'm not necessarily talking about ventilators. The ventilator decisions they make, those decisions are pretty early. You know, when they know they've got Alzheimer's and it's not going to get better, no, we don't want a ventilator.
Right.
But the ones they don't think about are artificial feeding tubes.
Okay.
You know, people think that starving to death they think it's cruel or they think it's painful, and it's neither one of those.
Okay.
There's a lot of research done. It's been done by the hospice facilities particularly. There's a lot of research papers out about starvation. Starvation is not a painful process.
Okay.
But
it's painful to think about it.
It's painful to think about
Yeah.
it, and it's you hate to think of your family member having that happen to them. But when you've got a terminal illness like that, and there's not any hope that they're going to get better and have any meaningful life, putting a feeding tube in someone to artificially feed them is no different than putting them on a ventilator.
Yeah.
And that's the biggest thing that I see that family members don't think about or are not ready to make that decision.
Right.
And I really, really encourage everyone to think about that scenario as well as a ventilator scenario and CPR scenario as soon as a diagnosis is made, because that's the toughest one that I see family members struggling with and fighting over.
Yeah.
And it's denial. A lot of it, they don't want to lose their loved one, and my goodness, who does?
Right.
But that's one of those things you gotta accept. If you're not gonna put them on the ventilator, don't put the feeding tube in, because it's no different.
Okay. Okay, Larry, let's switch gears now and let's talk about Parkinson's disease. Can you tell the viewer, again, a bird's eye view of what Parkinson's disease is?
Parkinson's is another progressive neurologic disease. It's a movement disorder disease that characterized by a tremor at rest, slowness of movement, difficulty with body positioning and movement, and then a change in affect or mood, a flattening of the affect or mood, and it's centered in a specific part of the brain and has basis based in certain neurochemicals that are in the brain, and it is a progressive disorder as well.
Do we know what causes it?
No, not to my knowledge. The body just is deficient in certain chemicals and or doesn't use certain chemicals in the way that it should.
Anything that can be done to try to prevent it?
There's nothing to prevent it, no.
Okay.
No.
Does it have genetic components? In other words, is it something does it run in families?
You know, there are just a couple of very, very rare types of Parkinson's disease or movement disorder diseases like Parkinson's that run in families, but not the generally accepted or well-known type of Parkinson's that you think of have any sort of genetic component. If you see it in a family member, then you need to think one of the rare hereditary-based type Parkinsonian disorders.
Yeah. Larry, how do you diagnose Parkinson's?
It's basically a clinical diagnosis based on the picture of the tremor and the rigidity of their movement, rigidness of movement,
Okay.
and flatness of their affect or their mood.
Okay. What is the way that you stage the disease? And what is the life expectancy when someone has been given the news that they have Parkinson's, typically?
You know, the Parkinson's, again, it can be any. That one has a longer life expectancy just depending on how they respond to medication and how severe it is. That
Okay.
can be anywhere from 10 years to 20, 25 years, just depending on the process, and even longer on the life expectancy.
How does it affect the mental functioning?
You know, interestingly, the mental functioning stays pretty sharp for a long, long time. And it's just the later stages that the mental functioning is affected that much. And that's kind of the sadder part about Parkinson's compared to Alzheimer's disease is they stay pretty sharp. They can't always communicate that to you as well as they'd like. And they may not look like they're as sharp as an Alzheimer's patient because as the disease progresses, they get what's called a Parkinsonian mask. And it's this mask where they just look flat, like they're staring blankly at you, but they may be sharp as a tack when they're doing that.
Really?
So it's very misleading. But their mental functioning stays pretty good. They deteriorate physically, usually, before they deteriorate mentally, as opposed to the Alzheimer's.
And the age range that you see?
Typically, you're going to see somebody in their mid-50s.
Mid-50s, that young?
At the onset of diagnosis.
Is that pretty typical?
That's typical.
Really? And so they might nearly live a full life expectancy even with the disease.
Certainly.
What kind of medications are there that can be used to try to retard the progression?
There's quite a few medicines now. When I graduated from medical school, there were probably only 2 different medications out there available that were used much in Parkinson's. Now there's 3 or 4 brand new medications. Some of them I'm not even that familiar with yet because they're so new on the market. That are being used with a lot more success to help with the movement disorders. And there's another one kind of on the horizon that's being developed that I've read a couple of papers about. So there's a lot more hope in terms of treatment of Parkinson's disease in terms of slowing down the progression of that.
Is it a very, for lack of a very poorly choice of a word, I guess, is it a very popular disease? Is it a very prevalent disease as compared to Alzheimer's?
There's not as many patients with Parkinson's as there are with Alzheimer's now. No, and it tends to be more prevalent in men, but not a whole lot. 3-to-2 ratio men to women on that.
If you were talking to the viewer about caring for a loved one with Parkinson's or someone who has been diagnosed with Parkinson's, Larry, what would you tell them?
I would tell them that as opposed to Alzheimer's, what you're going to experience is physical deterioration before mental deterioration.
Is there a lot of pain associated with the disease?
No, not really. Later on, when the rigidness gets worse and their joints become contracted, if you start trying to move them, there'll be pain involved with that. And again, in the later stages of the disease, when they're not able to move and get up out of the bed, then the risk of bed sores and things like that becomes a problem, and those, of course, can be painful because they can affect the nerves in the area, that sort of thing. So the later stages has some pain associated with it, but not generally before that.
Can you think of anything else that you would tell the Parkinson's patient or their family?
Well, again, probably the same things about deciding on end-of-life kind of care and legal matter type things. Again, it's a progressive neurologic disorder, and you can have some more rapid neurologic progression in terms of mental capacity with that in certain cases than compared to others. And so they need to make sure that their affairs are in order in terms of power of attorney and in terms of decisions about artificial life support and feeding tubes and things like that.
Okay. But the Parkinson's patient, I guess, until the very final stages of the disease are are still able to communicate pretty well with the family in terms of what they want and
Pretty
what
much.
they don't want?
Yeah, I mean, they'll get to a point where they can't speak,
Mm-hmm.
you know, necessarily,
Mm-hmm.
and their speech gets so slowed that it's very tedious and drawn out to try and communicate. But
Right.
they generally can. Yes.
Okay. Well, Dr. Larry Sharp, I really appreciate you spending time with me this afternoon in discussing these diseases, and I think that our viewers will certainly benefit from your expertise. Where is your office located?
I'm at the Clinics of North Texas,
And the address is
501 Midwestern Parkway,
Wichita Falls, Texas.
Wichita Falls.
Okay. What's your phone number there?
761-8522.
Okay. Dr. Sharp, thank you very much.
My pleasure.
Okay.